Next, we're going to have Dr. Samir Dixit from the Department of Orthopedic Surgery. He is one of our faculty in orthopedic surgery department. He's a primary care sports medicine specialist, and he's going to talk about some of the benefits, definitions, and strategies for the primary care providers. I'm an orthopedic surgeon, but it's when I think about the primary care providers, what they're trying to accomplish with patients in perhaps a relatively short period of time, screening and all the things that need to be done, as well as counseling patients on exercise. And so Dr. Dix is going to give us some strategies there.
Thank you, Dr. Schaefer. It's been a great day. I've learned a lot today. I learned your nickname was Schaefer back then. So,
my first name from college.
So, my perspective is one of an internist who did a sports medicine fellowship. My primary appointment's in orthopedics because of the patient population I deal with, but I have been in primary care. I've done a lot of primary care, so this is sort of a little bit more anecdotal than a lot of the talks that we've had today, sort of more experiential. I have no disclosures. I'm going to sort of talk about coronary artery disease, so I think it's the low-hanging fruit that we can use as clinicians to encourage other clinicians. Certainly, we've talked about a lot of other things here as well, and I'll refer to those, a lot of other diseases. I'm going to talk about how we measure exercise, theories as to why it's beneficial, review the literature on the benefits of physical activity on coronary artery disease. I know we've talked about a lot of this, so I may kind of skip through it very quickly at this point in the day. And I'm going to review some current guidelines regarding physical activity. I know it's late in the day, and the last time I played a video in this room, I told myself I'd never play a video in this room, but I couldn't help myself. So this is last month. This is 100-year-olds. This is a U.S. track and field race. This guy's name is Orville Rogers. This is not a skit. It's not Saturday Night Live. This is a real race. So I think, when we talk to our patients, that guy's 100 years old and he's doing that. I think we can certainly encourage most of our patients to go for a walk. So human ancestors incorporated strenuous physical activity as a normal part of their daily lives, hunting and gathering, as we know. As part of the healing process, we've known for a long time that physical activity is an important part of the healing process. Hippocrates advised people to exercise, but, quote, not too much. In India, they developed the principles of yoga 600 years BC, and in China, Tai Chi 200 years BC, in part because they were part of a healing process. With the Industrial Revolution and mass production, the concept of increased leisure time for the average person emerged. So physical activity, more specifically exercise, became a recreational activity versus a necessity for survival and work over time. More recently, quote that I saw that I think still applies: the exercise movement is not just a fad, it is a return to natural activity, the kind for which our bodies are engineered and which facilitates the proper function of our biochemistry and physiology. And that's what we've been talking about all day with all these body systems. Viewed through the perspective of evolutionary time, sedentary existence, possibly for great numbers of people only during the last century, represents a transient, unnatural aberration. I think when we talk to people, we kind of need to focus on this, and that's sort of a lot of what we've been talking about, I think, all day on some level. We've talked about physical inactivity. The prevalence of high school students who met activity recs is 27.1% nationwide, and it decreases in high school. And I think Dr. O'Connor referred to in Fairfax County, they stop a gym in 9th grade. That's actually pretty good. Here locally in Baltimore, it's even sooner than that. So part of what some of us have done is I've actually gone to Capitol Hill to advocate for physical education classes, schools, which are getting rid of as part of cuts. I think that we've seen a lot of these throughout the day, so I'm not going to spend much time on them, but there are very low numbers of people meeting the activity guidelines of the various organizations involved. And I think Dr. O'Connor showed this very number in his talk. 21.6% of adults greater than 18 met 2008 federal physical activity guidelines for both aerobic and strengthening activity. So I think what is the cost of this? And that people have tried to get to this. It's obviously very difficult to do. The economic cost of physical activity, according to one study in 2008, was estimated to account for 1.5 to 3% of total direct healthcare expenditures in developed countries. More recently, in 2015, they found that over a 5-year period, independent of BMI, inadequate levels of aerobic activity associated with an estimated 11.1% of aggregate healthcare expenditures. In 2015, our healthcare expenditures increased 5.8% to $3.2 trillion. And trillion gets thrown around a lot when you talk about the government, but I just put out the zeros there just to give you, I mean, that's a lot of money. A gym membership at Cooley here is $400. I believe it's free for students. So the cost of healthcare expenditure is almost $10,000 per person. That's 17.8% of our GDP, and that was in 2015. And I'm going to focus, like I said, on coronary artery disease because I think it's sort of an easy way to make the point. In 2002, prevalence of coronary artery disease was 70.1 million, 34.2% of the population. Since 1900, coronary artery disease has been the leading cause of death in the U.S. every year except 1918. What was 1918? The flu, yeah. So I think, I'm an internist. I deal with the whole body. I think all medical conditions are important, but coronary disease claims as many lives as the next 5 causes combined. And I think that's an important thing. If we have something that alters the long-term consequences of that, I think it's important for us as clinicians to focus on it. Acute interventions are kind of what we focus on as a healthcare system. My own uncle in this hospital has had these done, all 3 of these things done in this hospital. But it doesn't address the underlying lifestyle-related causes of disease. So kind of switching to how we define physical activity, there's 4 dimensions of physical activity: motor type, frequency, duration, intensity, and 4 common domains: occupational, domestic, transportation, and leisure time. Just some basic definitions of physical activity: any bodily movement produced by skeletal muscles that results in energy expenditure beyond resting expenditure. Exercise is a subset of physical activity that is planned, structured, repetitive, and purposeful in the sense that improvement or maintenance of the physical fitness is the objective. And then there's physical fitness as well. We have ways that we measure exercise. And then we all remember this. I know there's students in the room, so maybe it's not that much of a memory. Maybe it's what you're doing right now. This is sort of the metabolic energy production. Clinically significant key metabolic equivalents. These aren't perfect, but just to give you an idea of metabolic equivalents, this is sort of a rough estimate. These are some daily activities that you may do. And the kind of things that we do daily, even lying quietly, is a metabolic equivalent. So again, I think I'm in awe of some of the people that have spoken today, so I'm not going to spend a lot of time on the biochemistry, except to say that that's an important part of why exercise is important. It affects us on a biochemical level. In particular, for cardiology, the vascular endothelium is an important part of where we may be helping alter the long-term course of the disease. In epidemiology, there's been over 100 papers published regarding physical activity in coronary artery disease. Most are observational. Most find an inverse relationship between physical activity and incidence of coronary artery disease. And even into the 1980s, people were skeptical of this. So I think we are at a great point in time where folks like Dr. Martin can change this epidemiology and make it more numbers-based on what's actually happening. We're just going to outline a few of the basic papers. The first, one of the first papers that gets a lot of play was on the British Civil Service. It was published in Lancet in 1953. It was a prospective paper looking at almost 9,500 British civil servants between the ages of 45 and 64, no history of coronary disease at the time of entry into the study. And they obtained detailed self-reported physical activity on these folks. They found that folks that did not participate in vigorous sports had 5.8% coronary artery incidence. Folks that did participate had a lower incidence of coronary heart disease, and they had similar results when they controlled for other risk factors. They did not look at diet in this study. The U.S. railroad industry, they looked at clerks versus section men, and again, the same thing bore out in terms of mortality rate. Dr. Paffenberger is very well known in this field. In fact, the American College of Medicine has at least a lecture named after him, I think. And he was looking at Harvard alumni, and again, found that same relationship. Problems with these studies is they're observational. They don't prove cause and effect. There are no randomized controlled trials. How you measure physical activity is by self-report usually. And again, I think that's where some of the stuff that folks like Dr. Martin are doing is very valuable. Exercise varied over long periods of time, as it does in most of us. There were not many studies in women in the past. And there was a lack of control for dietary factors and lipids, which we know play a very important role in this as well. So how can you provide physical activity guidelines for your patients? And I would say maybe 10 years ago, I would tell my patients, there's a lot of fake news on the internet and stuff, but now I have actually found a lot of good resources on the internet. I would say one of the ones that I find most useful is the CDC website. To give you an idea of the gravity of this issue, is the CDC actually has pretty good exercise guidelines, and so I'm going to allude to some of what they say. I'm going to take it straight from their website. So we've already talked about the health benefits in children and adolescents, cardiovascular and muscular fitness, bone health, body composition, reduce symptoms of depression. In adults, I think we've talked about almost all of these things. I think Dr. McFarland, I know Dr. McFarland pretty well because I work with him, and he said virtually everything, and I think he kind of, as he often does, simplified it, and he was right. So looking at the CDC websites, they actually, and I've actually started sending my patients to the website in the last couple of years, and I think because getting back to sort of text message and stuff, you need something to reinforce what you say in a clinic. So they kind of say 2 hours and 30 minutes, 150 minutes of moderate intensity aerobic exercise. And we at symposiums like this or at conferences may argue about the time period, but I think this is a agreed upon time period over usually via some big players in the field. And I think even if they're off by half an hour, I think it's a good place to start. They also include muscle strengthening activities on 2 or more days that work all major muscle groups. And then you can see the other options there. And I think this is sort of a very basic thing, but I think it gives folks a framework who don't have familiarity with exercising. And then they even have another spot. Well, if you can get past that and you get conditioned, you've been doing that for a period of time, then try this. And I think that's what I really liked about this, is that it sort of works with you to kind of move this forward, because not everyone has a personal trainer, not everyone has familiarity with activity or sports. And I think if you click on these links, they'll give you some examples of what those activities could be. And then they have this, and I thought this was also very well done. We know that 150 minutes each week sounds like a lot of time, but it's not. It's 2 hours and 30 minutes, even 10 minutes at a time. So I've had patients who work down here, and I'll tell them to go from a walk from one building to another, and that's 10 minutes. This is a huge campus. And if they do that twice a day and they're doing it 5 days a week, they're getting pretty close to this number. And that's a start for the folks that aren't exercising. So I think whatever resource you use, I know that's not the only resource, but I found, because it's such a big group of people, I found it to be pretty simply written, which I think can help with folks who have challenges with health literacy. I think engaging, and I think Dr. Cheskin talked about this too. Why isn't the patient exercising? I think often it's fear with people that don't know how to exercise. I think time, we alluded to, poor self-esteem, poor body image. They don't know where to start. That's a lot of some poor conditioning. And there's other reasons, and I think a lot of folks have talked about that today. I think I think it's a cultural change. And one of the things is, when I started, 10, 15 years ago, nobody knew how many steps they took, except people that were a little bit odd, and now pretty much everyone will say, oh, folks who have an iPhone, whether or not they know it the last couple of years, if you're carrying your iPhone with you, it keeps track of your steps. Now, I don't know if Dr. Martin's still here, but that may not be perfect, in terms of the number of steps, but the iPhone keeps track of your steps, and I think a lot of people are purposely using other things to keep track of your steps. And I think the number of times I hear I get 10,000 steps a day is a lot. So I think there is a slow cultural change occurring. I think the other thing you want to do is set realistic goals. I mean, I'll have people who maybe need to be talked down from their goals a little bit, and that's okay, because if you have familiarity with what various activities are, you can kind of guide them through it. Diet is an appropriate part of this. I know we're focused on exercise. And then seeking professional guidance if it's appropriate. It's hard to start some of these things without being taught how to do them. I've found that that actually can keep me pretty busy, my orthopedic sports medicine practice. So I think having some guidance is important. Tell them to embrace the challenge, positive reinforcement, and then you can show them measurable changes in their health, which we do every time we see them. I think the other thing is we focus on modeled behavior. So I have, I think, ostensibly two bosses here. One is Andy Kosgaria, who's the chief of the Division of Sports Medicine, and one is Jim Fickey. So I used to think I was pretty active. I think my whole adult life until 10 months ago when I had a kid, I was mostly active, which is, I was lucky. I had the opportunity to do that, and I did that. Andy, Dr. Kosgaria, swims the Chesapeake Bay, and he swims it every year. He was a collegiate swimmer. He comes from a family of swimmers. And he told me on a Monday last summer, oh, you know, I did okay. I finished like third in my age group. If can't see it probably, but on there it says he's 40th in the whole race out of 620 people. I won't tell you exactly how old he is, but he's over 57. The next 5 people are like in their teens or in their 20s after him. And then there's Dr. Fickey, who spoke this morning. And so this time is 29 hours, 40 minutes, and 42 seconds. So it's a 100-mile race. He said he was a runner. He didn't say he was an ultramarathoner, which is what he does. So I think modeled behavior, that may be going over the top a little bit, but I will never be as active as either of these two guys. And that so certainly gives me a goal as to what to achieve. So I think the prevalence of physical inactivity is high. I think all these other diseases are very important. I mean, I've learned today about glaucoma that, you know, that was great. But I think even if you just focus on coronary artery disease as the leading cause of morbidity and mortality in the country, you can say there's a strong argument for physical activity. Clinicians need to do a better job of educating our patients and giving our patients strategies to exercise. Even moderate physical activity confers huge health benefits. And I think we need further studies to elucidate the optimal exercise regimen required for promotion of health. So that's it. I think I'm out of time. Thank you.
Questions? How about, Sam, what do you think, you know, the role is for this topic in medical school curriculums, residency, medicine residency, you know,
Yeah.
residency?
I think there's so much to teach that we don't focus on it. So I actually, an earlier version of this talk is actually for the medical students, but I also know that one talk probably isn't enough for a topic that can make such a huge difference in your patients' lives. So I think we, you know, there's so many things to focus on. I think it's clear that this could completely change our patients' lives. So I would encourage for it to be a bigger part of the curriculum.
Well, it sounds like the CDC website is a good tool for not only patients but providers too.
Yeah, I would.
Yeah. Good. Thank you very much.
Thank you.